Welcome to the July monthly infertility workshop that we started doing this summer. This month's focus is about frozen embryo transfers and the 2-week wait. And I'm so excited that you're here. This is definitely a safe environment where we are here to support and encourage and learn from each other. It is so awesome that Dr. Likes is here to join us and giving up his time to share some of his knowledge about frozen transfers. There was a worksheet that was mailed out to everybody. And so if you had access to download it or look at it, it will help with some of the notes. So I encourage you to look along and follow along with it if you had that opportunity. If not, don't let that hold you back. And we're just really glad that you are here and joining us. And for anybody who does, because I do record this and we'll share this later, if anybody's watching this on sort of the replay or the recording, you can sign up. I will include links to sign up for future workshops so you're aware of them. And also to follow Dr. Likes or on his Instagram account or my own, I will include those links as well below. So all of that being covered, that's the housekeeping. We are going to start with Dr. Likes, who I got introduced actually because of my infertility doctors. One of them works at his practice, and so that's how we made the introduction. And we started doing these workshops this summer, and he works at Fertility Center of the Carolinas, which is in Greenville, South Carolina. And I'm just going to pass it over to you, Dr. Likes, so that you can get started.
All right. Thanks, Kristin. So I do recognize a number of folks' names and faces, but I'll introduce myself as if I don't know all of you. I am Kristin Likes. I'm the medical director at the Fertility Center here in Greenville, and my training was in med school in Charleston. I actually did my residency here in OBGYN in Greenville, South Carolina, and then I did fellowship at Duke, and I've been back here for 10 years now. So that's me. That's my background. I'm born and raised South Carolinian. So it is great to see in New York, and I see a Syracuse t-shirt that I think I've seen before as well. There you go. So like Kristin said, we're going to talk about frozen embryos, but I'm going to first start by kind of dovetailing with what I ended actually on with my last conference, or our last conference, when we talked about IVF in general, because I think it's important to note the difference between frozen eggs or oocytes, that's in the worksheet, versus frozen embryos. And so I'm just going to go along with the worksheet. If you have it, you can follow along. Otherwise, just listen in. So there is a big difference between a frozen egg and a frozen embryo. And there's a multitude of reasons to do one or the other, or sometimes even both, which I'll get into. But just let me clarify, frozen egg is obviously one that has not been fertilized with a sperm. And so it's frozen for later use to try to be fertilized. And again, there are a multitude of reasons, whereas a frozen embryo is an egg that's retrieved, fertilized with sperm, and then frozen as the embryo state, again, which we'll get into. The biggest thing that you have to realize is in terms of the difference in the future use of either a frozen egg or a frozen embryo is the thaw rate. And so if anything's been frozen, obviously it has to be thawed out to be used. And there is a difference in the thaw rate between an egg and an embryo. The thaw rate for an egg, what I tell patients, it typically takes about 5 to 6 frozen eggs to equate to maybe 2 or 3 embryos in the future. So there is an attrition in terms of the thaw rate, whereas a thawed embryo is typically a 1-to-1. Usually a frozen embryo will thaw and result in an embryo that's able to be used. Probably less than 3 to 5% of the time does an embryo not make it through the thaw. So that's one big thing in terms of future use from frozen eggs and frozen embryos. So then that begs the question as to why do one or the other. So for the reasons for oocyte cryopreservation or egg freezing, which you may have heard of, and that's what I ended on my last talk last time. Reasons for egg freezing, one of which is actually a cancer diagnosis. So women who have had a cancer diagnosis, who maybe either have had children or have not, and they have a chemotherapeutic regimen coming on that may diminish their fertility, they can freeze their eggs before they go through the chemo. That's one big reason we have patients do egg freezing, quite honestly. A second reason would be if a patient does not have a partner and doesn't choose to use donor sperm to create embryos, she can freeze eggs for future use. And this is seen a lot in folks who have postponed childbearing, postponed a situation where they're ready to have children with someone. And this is seen more and more as well. In fact, there are what are called egg freezing parties for women who are 35, 37 or less. Typically in the Northeast and out West, there's an egg whisperer on Instagram I follow. I don't know if you know her, but that's a very large contingency now in terms of freezing eggs. Another reason would be to donate. So there are folks who find it as an altruistic manner to donate their eggs, and those eggs are frozen for future use because there are now egg banks in this country, just like there are sperm banks in the country. And then last, something that's sometimes not thought about is if a patient or a couple goes through IVF, and let's say we were able to retrieve 40 eggs, which can happen, the question is, do you use all those eggs to try to create embryos? And so as you can imagine, this is an ethically charged arena. And so some folks don't want to have that decision-making of what do I do if I have an excess number of embryos. And so sometimes if we have that many, we can tell the patients, well, we'll try to fertilize 15 or 20 eggs, and any excess mature eggs we can freeze for future use. And that may get around some of their ethical dilemmas. And we've done that as well at the office. So that's why folks are doing egg freezing and other reasons. So embryo freezing, so reasons for frozen embryo transfer essentially is what we're talking about. So the last conversation or conference we did that I was involved with was IVF and the process of actually creating the embryos. So going through the whole IVF process, retrieving the eggs and creating the embryos. Now we're kind of going the next step in terms of what do we do with those frozen embryos. And so let me back up and say there's different reasons that folks choose to freeze embryos. I will tell you, and a lot of you may already know this, a number of folks or clinics around the country have gone to what are called freeze-all cycles, meaning all the IVF centers do the IVF process with the couples, and then no matter what, they're going to freeze the embryos for later use. There are reasons for that. So a couple reasons. One, if a patient is going through her IVF cycle and her estradiol level, which is the main hormone that the developing eggs will make, if it gets really high, there is some data in the literature that says maybe we shouldn't do a fresh embryo transfer, which you may have heard of in the past, just freeze them all because it may have a better success rate. Also, along those lines, if a woman's estradiol level goes too high, she could have what's called OHSS, which is ovarian hyperstimulation syndrome. And we know that if a patient gets ovarian hyperstimulation syndrome in their IVF cycle, there are 2 waves where they will feel kind of crummy. And what I mean by that, they can feel bloated, they can feel nauseous, they can have severe symptoms of electrolyte imbalances and clotting factor issues. And the 2 waves occur around the egg retrieval, and then the hormones go down. But then if they get pregnant, that wave comes back up. And so we don't transfer in a hyperstimulation syndrome to prevent that second wave of symptoms. And so we just let it ride out. It's usually self-limiting. The patient gets better, and then she comes back for her embryo transfer later from those frozen embryos. A third reason, which is very, very popular now, is pre-implantation genetic testing. So that's where we can actually test embryos for their chromosome makeup. So we know that probably 75 to 80%, the vast majority of early miscarriages, regardless if it's IVF or natural, the vast majority are due to spontaneous chromosome abnormalities, meaning nothing that the sperm or egg carry, just happens. In terms of, when I say carry, it's not like a familial thing. It just happens in nature, and it happens in IVF. And so PGT is a way that our embryologists can actually biopsy a few cells from the embryo, freeze the embryo, and then those cells are then shipped off for analysis to get the chromosome makeup to see which embryos have what's called a euploid state, or a normal chromosome complement. And then those embryos are frozen for years if need be. And when they come back later for the transfer, we know which embryos have a normal chromosome makeup. So PGT is a very popular mechanism. We probably use it about 40% at least of our cycles. I just actually talked to a new partner who's coming on with us today, and she came from California, and she used it much, much higher than that. So it's very, very common, PGT. Another reason for frozen embryos, delaying the frozen embryo transfers, to defer childbearing. So I had a couple this week who were in their early 30s. They knew they wanted to have children, but they weren't quite ready now. And so they said, well, various reasons, whether there's a family history of something, or for ovarian reserve is low, she may choose, or they may choose to go ahead and develop embryos, freeze those embryos to preserve kind of being time of the essence, preserve for future fertility and come back later for a frozen transfer. And then there's also, along those same lines, embryo banking. That also can be along the lines of PGT. Again, I had that conversation this week as well. Someone knows that she wants to have, or they want to have 3 children, let's say, and she's 33. They could choose to go ahead and create embryos, get the genetically normal embryos and freeze them and come back sequentially one after the other to try to have those children. And those are 32-year-old eggs, as opposed to if she waits till she's 36, 37-year-old eggs, which is leading to other issues in terms of potential age-related reproductive issues. So those are the main difference between egg freezing and embryo freezing and future FETs. But the biggest thing, again, is the thaw issue. And so let's say you've gone through your IVF process. We've frozen your embryos. We're focusing on embryos now, no longer focusing on eggs. So you've frozen your embryos and you have X amount of embryos frozen. So what is that number? What I tell folks all the time is, regardless of how many eggs you are able to retrieve, if you have 4 to 6 embryos that are frozen, that's a really good number. So it's just like anything else. I think you've heard me say there's a bell curve in medicine, and 4 to 6 is kind of right in the middle. I've had patients have more. I've had patients have 1 or 2, or sometimes none, unfortunately, to freeze. And so we just remember 4 to 6. So then the question is, when you're ready for the transfer and try to conceive, what are the protocols? So the next line on that worksheet are the FET protocols, and I call pitfalls. So protocols, let me just say that there are a number of protocols out there. You can talk to probably 10 different REI doctors and you'll get potential 11 different protocols that could be used. There are a number of protocols. But the biggest thing that we look for is some sort of balance between estrogen supplementation, endometrium, which is the lining of the uterus, getting it thickened, and then architecture of the lining of the uterus, which I'll explain in a minute. And then you have to add in the progesterone supplementation, because essentially what we're doing in an FET protocol is trying to mimic what a natural pregnancy would do with spontaneous conception. And so what happens is, typically the FET protocols involve some sort of preparation to kind of keep your ovaries at bay. Birth control pills are a very common thing, and then you have a cycle, and then we start giving you estrogen to and again, there's a multitude of ways to do that. We use pills. We've used estrogen patches. You can have vaginal estrogen pills as well, but we try to get that lining built up, because that's what the estrogen will do that you're taking. And then typically what will happen is we'll do an ultrasound about a week before a suspected transfer should happen, so about 10, 11 days into the estrogen supplementation, and we look at the uterine lining with an ultrasound. So I mentioned architecture, and what we look at is we look at the thickness. There's no magic number. You'll hear 7 millimeters or higher is kind of what we like, but I've had plenty of folks who have a transfer at 6.5 millimeters and they get pregnant. But it's really the architecture. There's something called the trilaminar look, and that's how it looks like to us on ultrasound. And that's what we're looking for. And we typically will draw an estradiol level and a progesterone level to see where you stand after you've done that supplementation, to see if we're in that, quote, sweet spot. And then once you start the progesterone, you will have your transfer about 6 days later. Again, different clinics have different protocols, but that's usually the window of implantation. And so that's the protocols. Again, that's the overarching theme in terms of estrogen, progesterone supplementation. How that's done can be different from one clinic to the next. And this is where I usually say the caveat that if folks on this conference are seeing other physicians, I'm not saying they're doing it wrong. This is not medical advice for your FET. It's just a matter of how we do it. But again, we also have multitude of protocols as well. And I'll get to that in a minute in terms of what we see from your previous cycle if we need to change anything if it's not successful. And so in terms of the pitfalls, so I mentioned that there are certain steps along the way that we need to do to ensure the ovaries are quiet, the uterine lining is getting thickened, the architecture looks normal, your estradiol level is where we want, and that's, quote, sweet spot. Those are the pitfalls, because That doesn't always happen like we want, nor does it happen like the patient wants. And it's very frustrating. Believe me, we understand that. So one of the things that we have come about is what's called a chronically thin endometrium, meaning the lining of the uterus. We know the estradiol level is right because we check it in the blood, but for some reason, the endometrium is not getting thickened. And I'll be honest, it blows my mind from a physiologic standpoint why that happens. We don't always have that explanation, but then we can switch the protocol, or we can at that point add vaginal estrogen, because that's a very good absorptive area, and the uterine lining may respond better from that regard. I mentioned the architecture of the lining. Sometimes that trilaminar look or appearance isn't there after 10, 11 days of estrogen. If it's not, then we may continue that estrogen and repeat that ultrasound in a few days to see if we've achieved the trilaminar architecture that we're looking for the lining. The estrogen level is the same thing. Typically we want it over 100. I've seen as little as 100 to 1700 on estrogen pills that we give. But we like it over 100 essentially. And then the other thing is the thaw rate. So the big thing that you have to realize is we don't, quote, test thaw embryos, right? Because you can't take them out of the liquid nitrogen, test them to see how they're going to do, then put them back in terms of preparing for a transfer. So the thaw rate I mentioned was about less than 3 to 5% to, quote, lose an embryo from the embryo thaw. We do that the morning of the embryo transfer. So there is a little bit of anxiety there in terms of when I see patients, they say, how'd it survive the thaw? And so that's another potential pitfall that can be devastating, quite honestly, if the embryo does not survive the thaw. Even more devastating is if there's only one frozen embryo and that happens, and then we're left with nothing to transfer. Because if there are multiple embryos, and we usually at our center will freeze embryos on separate what are called straws or canes or whatever, so one cane equals one embryo. And so we're only thawing one at a time. But the day of the transfer, if you have multiple embryos frozen and the first one doesn't thaw or survive the thaw, then we can go to the next one and it doesn't postpone it other than about 30 minutes. And so you don't have to go through the whole cycle again, which is really good. That has happened. I've had both sides of that happen where there was only one and didn't survive, and I've had it where it was one and we just thought another one and she conceived. But again, that can be very devastating for sure. So the transfer day itself, I'm sure you'll read a lot about that. It's in the grand scheme of the IVF process, patients will tell me that that was a lot easier than anything else I did through this whole IVF process, right? I realize I'm the only man in this conference, so I can't really say that's the easiest part because I don't get it. But from my experience, that is definitely the easiest part of the IVF process. What happens the day of the embryo transfer? So what happens is you'll get a time for your transfer. We'll ask you to show up about 20 minutes or so ahead of time. There's no sedation involved like there was for the egg retrieval. Your partner is usually there with you if needed. And then we take you to the procedure room. And again, everybody has their different rooms, but we have our own procedure room. And it's a lot like a pap smear. You're actually on the same, with us, you're on the same bed that you did your egg retrieval. And sometimes that harkens back some memories and I get some funny comments, but you're on that same bed and you have a speculum exam, again, just like a pap smear. We have an ultrasonographer in our room with us who's doing an abdominal ultrasound. So throughout the process of IVF, you have vaginal ultrasounds. This is an abdominal ultrasound where we can put it on your abdomen and look at your uterus, its position, look at your uterine lining again, and kind of gauge where we need to go. And then what typically happens is for us, our embryologist will load the embryo because our lab is attached to our procedure room. They'll load the embryo in a catheter and they will walk it around to us into the procedure room. And we've already got the cervix in view, and we place the catheter, which is no bigger than the width of a pin, typically the pin top that you write with, place it through the cervical canal into the uterine cavity, again, all under transabdominal ultrasound guidance. So we know we try to get a little bit away from the top of the uterus, and there are various reviews and literature in terms of how far you go distance-wise, but we try to get in the thickest part of the lining is usually what I tell folks. And we do the transfer. It literally takes, once the catheter's in, takes about a minute. And then we withdraw the catheter and the embryologist will take it back to the lab. He or she will look under the microscope, flush that catheter to ensure that the embryo has indeed transferred, because embryos can get, quote, sticky, and they can stick to the catheter itself. I've had that on very rare occasions happen. It's very rare, but it can happen. So we just ensure that it did actually get transferred into the uterine cavity. And then once we get the okay, that's it. That's the embryo transfer. And we actually let you sit for about 5-10 minutes, and then you get up and get dressed and go home. That's the embryo transfer day. And then Kristin's obviously going to talk about the 12-day wait. It's 2-week wait that Kristin's going to talk about. The other thing I'll mention is that you'll hear about is what's called ESET, which is elective single embryo transfer. And regardless of if you're talking about a fresh transfer, but again, I'll be honest, there are very few centers that are doing fresh transfers, but elective single embryo transfer is very, very popular. I just looked at our numbers, and we have about a 90% rate of an ESET. And we are actually very proud of that, because I tell folks, certainly if you've done PGT and you know that this is a chromosomally tested embryo that's normal, the chances of success are not going to greatly increase if you transfer 2 versus 1. The only thing that's going to greatly increase is your chance of multiples. And in our field, we are very adamant to try to reduce the rate of multiples if possible, not only for obviously the mother, but for the babies as well, because we know outcomes can be more risky for both mother and babies. And so you'll hear ESET a lot, elective single embryo transfer, and we typically will do 1 at a time. And that's just a testament to the technology, quite honestly. The other thing that I'll mention are, people question success rates, because if centers are going to these freeze-all cycles, why are they doing that? Is that a good thing? Are the success rates as high? I will tell you, historically, the gap between a success of a fresh transfer versus a frozen was wide. The fresh used to be a lot higher in success, but we were also putting a lot more embryos in for fresh cycles too at that time. Now that gap has tremendously decreased in terms of success. And again, I just got our numbers from my embryologist, and through 2020, I usually quote folks at 60 to 65% success. And that's actually right on for us. And that's actually a clinical pregnancy rate, which means you've had an ultrasound and a heartbeat. So that's actually really, really good. So the chemical rate, that's another thing. A positive pregnancy test, meaning a blood test, is actually probably higher, because there are unfortunately going to be some that don't make it to a clinical pregnancy test with a heartbeat on the ultrasound. So a 60% clinical pregnancy rate is actually really good from a nationwide standpoint. You can compare. But I think with that, Kristin, I might stop. I always go over. I don't think I did today, so that's pretty good. But I'm going to be around for questions and answers later, and then I'll probably skip out for the support group. But anyway, that's my spiel right now for the FET.
That's great. Thank you. I don't want to hold anybody back. Does anybody have questions right now that they want to ask while he's just brought up all the sort of medical technical terms? You can unmute yourself, or you can ask a question. Okay.
Hi, Dr. Legs. Quick question.
Yeah.
Have you ever heard of the FLAIR protocol for people who don't produce a lot of eggs?
Absolutely. The Lupron FLAIR. Mm-hmm. So I'm doing one right now. You're talking about IVF. So we're stepping back in terms of creating the eggs, obviously retrieving and creating embryos. So yes, the FLAIR protocol, that's one of 3 main protocols for IVF. The Lupron downregulation or Lupron downregulation is one. Antagonist is another, which is very, very common these days. And then Lupron FLAIR. You're right. Lupron FLAIR is kind of, let's throw everything at the ovaries we can to try to get them to produce hopefully a good number of eggs. And the reason it works sometimes is what Lupron does. So I just mentioned 2 different cycles or protocols with Lupron. If a woman takes Lupron for days and days and days and days and days, eventually it will actually suppress their pituitary from getting their ovaries to produce eggs. But if you give it in these short bursts, that's why it's called a FLAIR, it actually will help, hopefully, optimize egg recruitment and egg production. It is the least of the 3 protocols used. It's kind of let's try this. if we've either done cycles before and the egg number has been low, or if our AMH is low and we've, again, done cycles and the egg production was low, that's usually another mechanism. It's used, but again, it's more rare than the other two. And I will say that if you look at the success, historically, it's the success of a flare is lower than the other two, but there's a selection bias there because, again, you're having folks who have had a lower number of eggs, and now you're doing this flare on them. So it's a selection bias in terms of the success rate, if you think of it that way.
Good question. Okay, does anybody else have questions before I start talking about the 2-week wait?
I'll ask one. When you have people that have lower numbers of frozen embryos, what does that usually look like with you as far as transferring? I know we're definitely going to do a single embryo transfer. But how many frozen transfers do you kind of go through before you go, maybe this isn't working, we should reevaluate you before depleting your frozen embryo stash?
Yeah, no, that's a great question. And that's kind of what I meant, and I didn't go into it, so thank you for asking. That's kind of what I meant by, if you've done some cycles, 1 or 2, and everything along the way, we're going to go back and check, right? So we're going to check the lining. We're going to check the architecture. Was anything different? Could we change the estradiol level? You're right. I mean, obviously, we're not going to do the same thing over and over and over and over again. Do I have patients that unfortunately fail their first frozen cycle and I don't change the protocol because everything looked like it should and perhaps we fell on the wrong side of the percentages? Yeah, we do have that a decent amount of time, unfortunately. 40%, right? Or 35%. And so we do realize that, but you're right. I'm not going to keep doing that for 3 or 4 embryo transfers because, again, oftentimes what we'll do is look back and say, what haven't we looked at? Do we consider a hysteroscopy if it hasn't already been done, which is a surgical procedure, or laparoscopy to look at the inside of the pelvis? Do we consider, there's a lot of tests out there, and I'll be honest, there's this ERA test, which is the endometrial receptivity test, that some centers do often, some centers don't do at all. We actually had this conversation today because it's Wednesday and our IVF conference is at noon on Wednesdays, where we're going to do this on one of our patients, but I have never done it. I know people who have done it, but the most recent literature says it's questionable, except in those who have done number of cycles and everything has looked right. And then you say, okay, what gives? Can we try this? It's kind of like a last-ditch effort, I'll be honest with you, in terms of, is there anything we're missing? I will also tell you, and some on this conference may know, I developed at our office we call it the hybrid FET, where we add additional mechanisms to try to offset things like immunologic issues, chronic infection or occult infection issues, thrombophilia issues. I mean, so I have a protocol that I put in place exactly why you do ERA. If you've done these cycles and you've failed, or for chronically thin lining, we also use something called tamoxifen sometimes in these cycles. We've had actually great success, over 50% success rate in these folks who have otherwise failed. And so that's what I mean by there are a multitude of ways, but we kind of go back and say, what haven't we done, or what have we missed, or what could we potentially change? But you're right. I'm not going to go through 4 FETs, and I would still probably just do 1 at a time. I have a patient who's transferring to me from another clinic who has had 5 miscarriages. She's done PGT. She's had 2 failed pregnancies from IVF on PGT, and she's going to do the hybrid. So I'm knocking on wood. I'm hoping that's going to be the thing for her, but I can't guarantee it.
Thanks.
That was a great question. And we had a question in the group chat too. How many years can frozen embryos be safely stored?
The short answer to that right now is years. And I'm not being flippant. It can be, I can't remember the longest we've had, but it can be years. That's what I mean about the technology. So again, today we have another transfer of embryos coming to us from an outside clinic that were frozen 6 years ago, and she's going to use them now. The biggest thing is how they were frozen, because again, technology changes, and our embryologists have to thaw these embryos. And I talked about the straws and the canes that these embryos are frozen on, or if we used to freeze them in pairs, or sometimes even 3 at a time. So you have to keep that in mind. You can't, if they're on the same cane, you can't thaw one and not the other if they're together. So you're going to thaw both at the same time and potentially refreeze another. How they were frozen in terms of the technology back then sometimes leads to questionable thaw rates. We've actually had to change how we thaw things based on what they were frozen on in the past. But we have very good embryologists, and I trust them with that because I'm not doing the thawing with the liquid nitrogen. But they can be frozen for years and still be healthy.
I have a question.
Thoughts on the scratch test? Sorry, Elizabeth. Go ahead. You go ahead. You had it first.
Mine was just real easy. So we just did our final transfer last Thursday with Dr. Miller, and I was comparing my 2 FETs, and the only thing that I noticed changed, and I was just curious as to why, is this time I took doxycycline for a while, and I'm still taking prednisone right now.
Yep.
I didn't know if that was added because of COVID or like,
No.
I didn't know what. I didn't know. I was like, why am I doing this?
So I'll tell you why. Because you are kind of in a, so I know Elizabeth. So you're in a.
I don't care.
Okay, you're in a hybrid of my hybrid. So okay. I did that to potentially lower any kind of immunologic or occult infection. That's why you're doing it.
Okay, I was just curious.
Yeah.
I go Tuesday to find out.
I know.
Oh, I guess you do.
Oh, so there was a question about the scratch test. So what that's referring to is the endometrial scratching. That's what the term is. Basically what that is in preparation for a future transfer, we will do oftentimes what's called an endometrial scratching, where it's a small, what's called pipelle. So it's like a small curettage, tissue taken from the lining of the uterus. That initially came out on what's called up to date in terms of patients who had failed previous cycles. Kind of, again, can we do something to figure this out in terms of why they're failing when everything else looks good on paper? And the scratch test has shown that in folks who had previously poor implantation, it may have what's called a favorable decidual reaction and help the uterine lining heal, and then in the subsequent transfer cycle have a better success. It only came out for previously failed implantation patients. Do some clinics, us included, have used that across the board? We have. We've kind of gotten away from it because we didn't see a significant success bump. But that's what that scratch test is there for in terms of what it came out from the literature. So what can you do to assist in higher success rate of IVF? In terms of from our side, from the patient side, there are so many things. You're right. Patient side. So tell us the secret. I wish I had that secret. So from the patient side, again, what I tell you is everything in moderation. I know I have a nutritionist on the panel here, so I'm not going to go into gluten and all that because that was just done. Yeah. I will tell you everything in moderation. Do we have folks go on supplements that are doing IVF? And the supplements that we typically do are vitamin E, vitamin D, CoQ10, those sorts of things. Absolutely, we do. We don't think that's going to hurt. We actually think that may help with egg quality. If you've been diagnosed with PCOS, oftentimes, or not often, most times we'll put you on metformin because we also think that can potentially help with egg quality. But short of that, I always say, there's a lot in this field that we don't know that are going to affect the outcomes in a negative manner. And if we don't know, we can't test for. And that's very, very, very frustrating. I know it's frustrating for patients, and you can trust me, it's frustrating for us as from the physician side. But if it's not like that, it'd be 100%. I mean, I'm very happy with very pleased with 60 to 65% success rate that we have. But there's just inherently going to be something that we can't test for and therefore can't correct. But I do think, if you stick with it, over time, the success rate is going to be there for you. All right. So,
yeah. So I was just pointing out that the first workshop we did was about what to do when you're waiting for your appointment, because we started it doing when all the offices were closed. And so Dr. Likes really did cover what you can do as the patient from home with supplements and things like that. And then last month, we had our nutritionist join us, Laura. And so she shared all about diets and related to that. So Liz, I'm happy to share those replay links with you, because we spent a lot more time going deeper into that versus Dr. Likes just repeating little snippets right now. So we'll talk after this so that we can get that to you.
That'd be great. Yeah. Thank you.
Because there definitely is things that you can do to improve your chances and to make it so, because part of it is also just not having regrets and feeling like you've done all that you can within your control. And so one of those is your diet, and one of those is, supplements and other things that Dr. Likes talked about in that first workshop. So I'm happy to share that with everybody. Okay. And, all right. Well, just looking at the time, Dr. Likes, do you feel good?
Yeah.
right
Yeah,
now for that?
absolutely. I
Okay.
think you should go ahead with your side. And Elizabeth, do you want to ask it now, Elizabeth?
Yeah, I just have one more question, and it probably doesn't deal with anyone else but myself. But I'm a teacher, obviously, and there's just a lot of anxiety about going back to school. Should I be pregnant? What are your thoughts? I'm sure y'all are getting a million questions.
Yeah. See, I know you're talking about COVID, obviously.
Oh, yeah, sorry. I just
Yeah.
assumed everybody knew that at this point.
I know what you're talking about. So here's my Switzerland answer to that. So there is a paucity of data on COVID in pregnancy, especially in early pregnancy. So we don't, unfortunately, know exactly what's going to happen. There are preliminary data coming out showing that pregnant women may, if they get COVID, may show more severe signs. So if you remember back in H1N1 time, when it was 2007, 2008, H1N1 was affecting pregnant women significantly higher than non-pregnant women. It may be similar to that, but other than that, we just don't know. There has been, I think in France, in utero transmission of one. There's limited data on vertical transmission, meaning at delivery, if it can be transmitted. There have obviously been children or babies born with COVID and have done well. So unfortunately, it's up in the air. We don't know. What I answer to that question is follow the CDC guidelines of social distancing, mask wearing, cleaning your hands, and avoiding folks who may have been around somebody or who have had it. Short of that, it's very difficult. Let's put it this way also. I don't have a lot of people. I still have a lot of people trying and getting pregnant in this time. So
Yeah, sure. My biggest concern was when the suggestion was we go back full capacity.
yeah.
Now my district's I'm not supposed to know this, but they're not doing that. We're going to be on a hybrid model.
Right.
And I know, and the kids are required to wear masks in the hallways, but not in the classrooms. But I mean, if it were your wife, would you still, like, if I'm wearing my mask, I'm staying away, washing, all that stuff, would you feel comfortable?
Yeah. I mean, I also
don't want to teach virtually, teaching special ed virtually is ridiculous.
Right. I also, you also have to look at the numbers that are coming out in terms of the transmission rate from young children. It seems to be very, very low.
And all adults are required to wear masks.
Right. So I'd be okay.
Okay, because I've been not in a good place about it.
Yeah. It's a lot of unknown. There's no doubt.
Well, that's the part that's scary.
Sure. Right.
Yeah. Thank you.
Absolutely.
Okay. Dr. Lakes, there's one more question that showed up about what you should be doing during your FET cycle. So Kelly, are you meaning like at home, like working out? Do you mean?
Yeah, anything you should be avoiding. I mean, obviously when we go through IVF and stems, it's you don't drink, you don't do. Are there certain things to make sure you're definitely avoiding? Certain things are okay with moderation. Workouts are okay as long as you're below a certain threshold after your transfer until your 2-week wait is over and such.
Yes to all that. I just say everything in moderation, and you can still work out. And the day of, we just tell you just kind of take it easy. The day of transfer, that doesn't mean you have to go lay in bed the whole time. I mean, I think you just live your life, quite honestly.
Yeah, I think I'm not the doctor, but I think that, and this is funny because it comes from my mom, but her advice was always dress for the job you want. And so I think while you're preparing for the FET cycle, like get ready and prepare and act as if you're going to be pregnant, because that's the role you want to be in to a point. And then my OB gave me the best advice. And he said, if anything you do, if something bad were to happen, would you then blame yourself for that thing you did?
I say the same thing to patients literally all the time.
Do you really?
I absolutely do.
It's literally, it like changed my whole experience. And I knew that there were certain things, if I did them and something went wrong, I would blame myself. And so then I knew not to do it. But if I knew that like, oh, okay, I know that I've been, spinning my whole adult life, spinning now, I don't feel like that's really going to be the thing that causes a problem. So I'm not going to blame myself. So I can go ahead and keep up with that. So that's a really good barometer for each of us, because each of us have a different answer to that question.
Yeah. So to really quick to expand on that, there's a lot of peace of mind. I always say that there's a lot of peace of mind in what we do. And I get the question all the time, or different questions. Can I paint in a closed room? Can I go to can I get my hair dyed? Can I, all these things, and I tell them honestly, there's not going to be any studies to tell me that that's good or bad. But the way I answer is exactly what Kristin just said. I said, if you can avoid it, because God forbid something were bad to happen, you look back and you blame yourself for that one thing, and you could have avoided it, just avoid it. Take it out of the equation. If it absolutely doesn't have to be done, just take it out of the equation for peace of mind. That's how I answer that. So that's why I was saying, Kristin, that's exactly what I say.
Well, good. I feel like that's a good transition then.
There you go.
Yay. Okay. You guys, those were awesome questions. I just think it was awesome, the questions you guys were asking. So thank you for doing that. For those of you that are new and maybe only knew about me because of somebody on social media sort of telling you to go to my account to sign up, I'm Kristin, or Kiki is my nickname. And I actually had 7 official 2-week waits myself. And it was the thing that I hated the most. And I thought it was the hardest part of going through IVF was the 2-week wait period. And I lost a lot of sleep at night thinking, how can I make this better and how can I help other people? And for my last and 7th 2-week wait, I came up with the 2-week wait challenge, which was my way of trying to help other women like me going through it. And through that, then I became an infertility coach as well. And so now I help support on the emotional side, women who are going through IVF treatments and women who need a little bit more emotional help, somebody to hold their hand along the road, to know they're not alone, to get joy back, reduce anxiety, all the such. So that's what I do. And I just love being able to share the things that I learned the hard way with you. So the 2-week wait challenge is something I did where it's an automatic email that once you get your transfer date, you sign up for it and you get an email every day for your frozen transfer. Or it could be a fresh transfer too. And you get a daily email with some positivity, some encouragement, an activity to keep you busy, and just a way to get through the whole process. Because one of the things that I find being so hard about the 2-week wait is that there are so many steps and hurdles and 3 steps backwards and 2 steps forwards that got you to this point. And so there's a lot of pressure. And it's also the point when you feel like there's nothing more. There's nothing more that you can do to improve it. So you sort of feel like it's out of your hands and you have no control. It's called the 2-week wait in the general sense. Different practices, like Dr. Like said, will test on certain days. Also depends on the day of the week. But generally it's referred to as the 2-week wait, which, is 14 days or 1,209,000 seconds. And there are people who count. I mean, it's literally, the other term is that it's forever. It feels like forever. And I just don't like watching my life get wasted by and keep hoping and wishing for the future. and I really like to make the most of the moment. And so that's why the 2-week wait challenge started. And the hardest part, Dr. Lex, you were saying how the transfer day itself is actually pretty easy. I totally agree. I think the monitoring process ahead of it is there's a weird sense of like, wait, shouldn't there be more? Like, shouldn't there be more appointments or more changes? Because from the IVF cycle, you feel like there's a lot more that happens. And the transfer cycle is way simpler. The hardest part, I think, is the full bladder. Honestly, because you have to drink so much water and have this full bladder, and then you're about to be, in stirrups and you got to go. And it's like, that's the hardest part, honestly.
It does depend on how your uterus tilts. So people don't absolutely have to have that, just so you know.
Okay. Well, I also learned like you can fill it up and they can let it out too. So don't put yourself in total discomfort. But again, I learned that through my own experience. Yes, the Valium totally helps too. I enjoy that. Not everybody does that, but I think if your doctor allows it, say yes. Again, I'm not a medical professional, so follow what your doctor says. Okay. But this is the thing that I've learned about the 2-week wait is the lack of control is a big problem. And I find that people end up putting all of their nervous energy into the wrong things. And so I want to help you actually, I would love if you guys can comment and share, have you gone through a frozen transfer before? Like say I've done one, or no, I have a future one coming up and never done it before. I'm curious to know kind of everybody who's here, who's done them or not. Okay. Yes, Elizabeth, thank you. We're so excited for you. Okay. Okay, this is good. Okay, so it's a mix. It's a little bit of sort of both. So people tend to direct their nervous energy into the wrong areas. And so if you look at the worksheet, which I did, and I actually thought it might be a little bit easier too, because I think it's prettier. Can I do it this way? I was going to share my screen. Maybe not. Maybe I can't do it. Because I'm not seeing it. Oh, there it is. Aha. Okay. I just thought maybe instead of staring at my big face, this might be helpful too. So the things that people do and they think help but don't, one of them is Googling and Googling all of your symptoms and symptom spotting. And your doctors know a lot more than Google. Do not fight them on that. Google will send you down a rabbit hole. You will literally find information that supports either option, either outcome. And you're already nervous. You're already feeling all this pressure. And just don't go down the Google rabbit hole. Symptom spotting is another one where you're like, okay, because days 1 through 3, you're feeling good. You're like, this is it. This is happening. I got it. Woohoo. And then day 4 and 5, that's usually when people are like, I don't know. And it's either because you're feeling no symptoms or you're feeling, you're feeling no symptoms or you just spot fun blue stuff. I don't know what that means.
From
okay.
the vaginal estrogen.
Oh, okay. So
sorry.
That's okay. I was like, I don't know what that is. Okay. Symptom spotting is challenging because, and Dr. Likes can correct me if I'm wrong, but the symptoms for early pregnancy, the side effects of the medicine you take, and some of the symptoms that women have when their cycle is starting, their period is coming, can all be the same symptoms. Okay. I got the head nod that I was correct. So that is factual. Okay. That's good because I've been talking about that for a long time. So that's the thing. You could feel cramping and it could be implantation cramping. It could be your period coming and it could be from a side effect from the medicine. So symptom spotting does not help unless you promise to only look at every symptom as confirmation or affirmation that it worked. Because down at the bottom, I wrote that there's a term. So in the online world for infertility, people talk about being poopo or being pregnant until proven otherwise. I prefer a term called PASP, which is PASP, and it stands for pregnant and staying pregnant. because I don't want to wait for the other shoe to drop. I don't want to wait for somebody to tell me bad news. I want to believe that when the transfer happens, it is happening for the long haul. And so I like to think that, so Elizabeth, right now you are PASP. And that's, you know, that's so much better, and it's so much more optimistic, and it's so much more thinking in the way that you want, because I talk a lot about too, spending all your time and energy on thinking about what you want and not what you want to avoid. So symptom spotting, if you feel a cramp or your boobs get tender, or you feel exhausted, or you've lost your appetite, every single one of those, do not let yourself think that it's a side effect of the medicine, and do not let yourself think that it's because your period is coming. You have to tell yourself that it's because you're pregnant. Those are pregnancy symptoms. You are not pregnant until your doctor tells you. Not because you think it or believe it or because you have these symptoms. Wait until the doctor tells you. So Googling symptom spotting. The other one, peeing on a stick, like every day, 3 times a day. Y'all, don't do it. Like, save your money, save your sanity. There is so much of a roller coaster already that you are going through. You've already gone through so much of an emotional roller coaster. I would rather you go through the 2-week wait, believing that you're pregnant until you are told otherwise, or forever, and not pee on a stick and have the chaos of watching those lines get bigger or darker or not, and squinting and line eyes. Like, it's so much better. If you need to pee on a stick, do it the morning of your beta. If you need that's my only sort of, for all of my clients, that's my rule, is you are only allowed to pee on a stick the morning of your beta, because you kind of want to know, like, do you go to work or not? And, what is the phone call going to be like, to give you some direction. All of mine, I waited until I got the phone call. I never peed on a stick beforehand, but I really strongly believe in not peeing on a stick ahead of time. So out of that list, I want you, for when you have your next transfer, to think of 1 or 2 of these that you promise you're not going to do and make that promise to yourself, because you will save yourself the nervousness and anxiety as you're going through the 2-week wait if you promise you're not going to do 1 or 2 or 3 of those things. The fourth thing, which I didn't put a 4 here, but I'm just going to say it. So many people think that they're not going to let their hopes get high because they want to protect themselves. And I just want to let you know that that doesn't work. There's no way to protect yourself if you get bad news. And I think holding yourself back from feeling the joy of getting to this point of getting a transfer. I mean, Dr. Lights talked about some of the things that might make it hard or not happen. And again, there's so many steps, that weeks and months, and to get to the transfer date, to be PASP, like, or in the 2-week wait, like, you've already gone through so many hurdles. Like, enjoy that, being in that step, because that's the farthest potentially point you've been so far. And I really want you to enjoy that. So the best way to use your nervous energy during the 2-week wait is actually what's the real word I wrote down? Sorry, y'all. Is to use it for good. Use it for good. And here are different ways that you can use that nervous energy for good instead of peeing on sticks and instead of symptom spotting or spending time on Google. My favorite thing is to do random acts of kindness. And I love to put out good out into the world, because not only does the person who received your gift feel good, literally you feel better too. Random acts of kindness can be to literally a random stranger or just done randomly. So it doesn't necessarily mean like buying Starbucks for the person behind you. It could be like making a meal for the neighbor behind your neighbor, or writing a thank you note to the people in your life who've supported you all along the way. It could be writing a note to your nurse. If you've had a really good nurse along the way who's hold your hand, like write them a thank you note now, like do it now. So random acts of kindness is my favorite thing, and do it every day if you can. That's my favorite. You can use it for meal planning or trying different foods. You can use your nervous energy on the things that you control. So other things are moving your body every day, getting the sleep you need, making schedules. You can also, organize that closet or drawer you've always been thinking about. Like, now's the time to do it, before you start feeling crummy because you're going to be pregnant and the first trimester is going to be hard. Like, do it now. You can also use it to plan ahead. One of the things that I like to encourage people to do is have a plan for like the day after your beta. Because whether you get good news or bad news, you want to be busy and you want something to look forward to. So I really encourage people to spend their time to do that. The 2-week wait, you can do it. You can get through it. It can be awesome. But I think I just see people make it harder on themselves by doing those few things that I told you guys. And I really encourage you to not do it and to use that nervous energy. But also, if you're interested in signing up for the 2-week wait challenge, I did put the link in the worksheet. But that's something you can sign up as soon as you know your transfer date, and it just sends you the automatic emails per your day. So something to think about, where every day you're going to get another tip like that. Okay, now I'm going to read through the chats because I didn't get to see any of it. But were there questions?
Yeah, so Jenny had a question about Ashton's, and I'm scrolling back up to it. Sorry, I need my glasses now again. Getting old. Where is it? It said something about, do you do anything, what's your protocol? Here it goes. Is there anything different with the protocol for Asherman's? I think it's what it said, something about that. Right, Jenny? Yeah, what's your protocol with a patient that has Asherman syndrome? So just in case you don't know, Asherman syndrome is where there's scarring of the uterine cavity. And there's different degrees of scarring in terms of how scarred a cavity can be. Unfortunately, I've done hysteroscopies on a uterus that the cavity is completely scarred and does not have normal endometrium, and she doesn't have periods because of it. Scarring can occur from repetitive procedures or infection. I've actually seen tuberculosis of the pelvis. That can happen as well. It's exceedingly rare, but it can happen. The issue, Jenny, I would tell you is I don't think the protocol necessarily changes. It's a matter of the surgery getting ready for the endometrial preparation. So if you've had a hysteroscopy to clear out some what are called uterine synechia or the adhesions, oftentimes we can get them all out and restore the uterine cavity. And then really what's going to happen is we're going to see how the uterine lining responds to that estrogen supplementation to see if the lining can get thickened. Because in a scarred uterus, if it's significantly scarred and the endometrium or the lining has taken a hit, so to speak, it's not going to thicken. And so that's going to be your telltale sign typically. They'll probably also repeat what's called a 3D sonohystogram to make sure that they don't see any further adhesive disease in the uterine cavity prior to your FET protocol. But I think it's really the preparation that gets you there to the FET that's going to be the biggest thing. What did they see in hysteroscopy? How they felt they did in terms of clearing out the synechia and what degree of adhesive disease was there. That's probably the biggest. And then how you respond to the endometrial preparation. Is that, Jenny, you can send a message if that's okay for an answer. And if not, I'll try again.
Thank you so much.
From Ashlyn, it says, how long is the process from start to finish? Trying to figure out when I need to make an appointment. Yeah, I talked to Alice about you today. Honestly, the FET process is much, much easier than the IVF process because we already have the embryos. And so you don't have to go through the whole process of ovarian stimulation and retrieval. So literally we can pick a date for your frozen transfer. And then we just work backwards from that. Just like everything else we do in my field, it's all dependent upon your cycle. When your cycle starts, if you've had a recent birth, if you're still breastfeeding, we typically will not go into another cycle. That's another thing. What are your cycles regular? Those sorts of things. So we'll just kind of catch up, Ashlyn, in terms of history if I hadn't seen you in a while. And then from there, it's literally once you start your estrogen, like I said, we usually do birth control pills. And once we start your estrogen, we do that for about 11 days, do an ultrasound, and then you could potentially have your transfer 6 days after that. So it's relatively quick. I will say, like I just mentioned with the 3D sauna with the Ashermans, we will do a uterine evaluation before any kind of embryo transfer. So you can expect that as well if it hasn't been done within 6 months. Our timing is 6 months. So in the process of the birth control pills to quiet things, we'll do the 3D sonohystogram, the ultrasound in the office to make sure. So that's not a silly question, Kelly. It says, but coming off of birth control, do you have a period or go straight to estrogen? So you will have a period typically coming off of birth control, and then yes, we will start the estrogen shortly thereafter. Once your estrogen starts to build up, that's when your period will subside anyway. So, or it could do it naturally, because naturally what happens is your estrogen builds up from your ovaries.
Okay, well, if there aren't any more questions, then this is sort of the period where we let everybody else sort of unmute and put on their cameras if they want and do the support group aspect of it. So, yes.
I'm going to take off.
Okay, Dr. Likes, thank you for joining us. Thank you for the knowledge that you dropped and shared. So valuable. I know this will be really helpful for everybody who's listening. So thank you very much.
Absolutely. Kristin, thank you for doing this with us. You drive this boat for sure. So thank you.
Yeah, and if anybody who's listening is not a patient of Dr. Likes, you can totally call his office and schedule an appointment to be a new patient. Clearly, he's one of those doctors who cares a lot because he's doing this. So I think it's a really awesome thing that you do.
All right. Thanks, y'all.
Okay. Bye, Dr. Likes.
Bye-bye.
I just want to thank Dr. Likes for joining us again tonight. We really appreciate you taking the time and sharing your expertise specific to frozen transfers tonight. If anybody wants to follow him on Instagram, he is at KratenLikesMD. So please go ahead and follow him. If you're not already following me, I'm at TTC_Kiki, which is KIKI. For anybody who's watching this on the replay, if you want, please make sure that you sign up for future workshops. I'm doing these every month with a different subject. I just hope that it's helpful for you, and I don't want you to miss out on a future one. So I will include the link below to sign up, or even on the video. And so you don't miss out on future workshops. And I'm glad that you took the time to research and educate yourself, hearing from our guest expert, Dr. Likes, and hearing about the 2-week wait from me. And if anybody does have a transfer coming up in the 2-week wait and are interested in signing up for the 2-week wait challenge, you can sign up at the link that I'm also going to include here. You just need to have your transfer date included. So I look forward to seeing you at a future workshop, and thank you for coming tonight. Bye.